I'm currently a professor at OHSU in emergency medicine. I'm the MS section chief. And then let's see, make sure I get my slides moving here. These are my disclosures. Most of them have to do with research in different areas, including trauma and cardiac arrest. But I don't think anything applies to what we're going to talk about today. So I want to remind you what probably is the most important thing is the slope of death. This is something that is well known, has been publicized for many years, and that basically time matters in cardiac arrest. And remember this because this 10% loss of survival with each minute delay in someone who collapses to the time they get definitive care is what we're trying to prevent and correct in through our various efforts in terms of chain of survival in communities. But I also want to remind you something called the three-phase model of cardiac arrest. This was actually introduced way back about maybe for close to 20 years ago now by some eminent resuscitationists. And they basically talk about the fact that when you have cardiac arrest and it's sudden, unexpected, which is what we're really talking about today, that basically as myocardial ATP energy stores decrease in the heart, you go from what's called the electrical phase, where really the priority is early defibrillation, to the circulatory phase, and then and finally into the metabolic phase. And the important part is that in that electrical phase, which is at 0 to 4 minutes, the best things you can get in terms of outcomes there have to do with early defibrillation. And the classic example is this casino study where if you got shocked within 3 minutes, you had a 70% survival. Most of us in EMS arrive hopefully during the circulatory phase, which goes from about 4 to 10 minutes. And in that phase, really, it's about CPR and then moving ahead to do defibrillation. And then lastly, once we get into the scenario after 10 minutes, it's really largely about the metabolic phase, trying to figure out how we can make the setting better for the patient so that hopefully if we do get them, they get both cardiac and brain survival back. So these are the three phases. And when you think about what you're doing and how you're intervening, realize that this should be in the back of your mind along with that slope of death. So in terms of what's new, really, the chain of survival a few years ago was kind of expanded. It really talked more about adding a section called recovery, which I won't talk about today much, but I'm really going to go back to sort of talk about some of what I think are the key elements. So when it comes to BLS and basic life support, these are the sort of the updated European guidelines, and really. Their 5 top messages for BLS in 2021 was to recognize cardiac arrest and start it, alert EMS, start chest compressions, get an AED, and learn how to do CPR. And that's what their main focus has been. And as a result, in Europe, they've actually rolled out a number of things that are now also being looked at in the US. And some of these have to do with trying to get more people to do CPR. So the world has now established a date, October 16, 2022. This year will be World Restart a Heart Day. And the goal here is to train as many people as you can. So I hope you look at this as it comes out in your communities to try to bring people together to learn how to restart hearts, because these two hands that God gave us can save a lot of lives if used in a timely fashion. Kids can also save lives. So in the UK and also in Europe, they've been doing a lot of teaching, and it's been shown that if you use video games and other things, you can actually teach kids to do CPR. And they actually have similar competency, incredibly, compared to adults. So they're basically taught to check, call, and compress. And for most of us, this is trying to get pediatric we try very hard to get CPR programs into schools, starting at the 7th grade level. We do have a mandatory requirement in many states to have it in the high school levels, but you can actually start at the middle school levels, and it can be very, very successful. So this is important because we want to train a large cadre of people so they're very comfortable with CPR, and getting kids involved at an early age is really important. Why is this important? Again, it basically comes down to the fact that when you do CPR and you get good bystander CPR, you're going to get essentially prolongation of circulation to the heart, so prolongation of the ventricular fibrillation, and that will increase your survival from cardiac arrest. And you can see that the earlier you get bystander CPR, earlier you get professional CPR started, the better the outcome. So that's been the focus to a great extent in terms of why we try to intervene with the so-called slope of death. So earlier CPR really means bystander CPR, and what we need to do is figure out how to get people to do bystander CPR quicker, faster, and that should be a focus in all of your communities. There's actually some good data recently that came out in this publication from the American Heart Association journal that actually looked at what happens when you get bystander CPR. So these investigators out of Seattle actually looked at what we call the VF waveform. So when you look at a VF waveform, you can actually look at what's called its amplitude, its frequency, and also something under a combination thing called AMSA, which basically is a composite measure of how good the VF looks. It's called the amplitude spectrum area. And you can see on the left is an example of a really good waveform. And on the right, you can see an example of a less optimal waveform, both in terms of amplitude, frequency, and AMSA. And what they're basically were able to show in this paper is that if you got bystander CPR, that the VF waveform on arrival looked much more like what's on the left than on the right. So we now understand that what you're basically doing with bystander CPR is keeping that heart perfused as best as you can, so that that waveform that we want to see, which is VF, is going to be the most optimal one that responds nicely to defibrillation. So, the conclusion of this paper basically was that bystander CPR correlates with more robust initial VF, and that basically allows you to understand now mechanistically how CPR is working in the pre-hospital care. This brings me to the next thing, which I've talked about before to all of you, but I think it's incredibly important that we talk about telecommunicator CPR. This was actually brought together and as a synergistic partnership by Mickey Eisenberg from the Seattle King County system with public health. But basically what we've learned is that even though we can train a lot of people in CPR, there's some problems. People don't recognize arrests readily. There's a lot of confidence or lack of confidence in actually doing CPR. And then there's the competence with exactly how to do it. And so often people, even though they're trained, won't do anything. But having a coach on the phone through having a telecommunicator CPR person present was incredibly helpful. So in most systems where you have no telephone CPR, no good CPR by EMS when we arrive, and no rapid dispatch by the dispatchers, you can see the survival average is about 10%. And that's because if you go through the different pieces of how long it takes, about 2 minutes to get a call answered, about a minute for us to turn out of the stations, another 4 minutes and that's in a big city. In rural communities, it's even longer. And by the time we get to the patient side, start CPR, our survival rate, and at that point when we defibrillate, is 10%. So we're way down on that slope of death. But if you can get a change in the system, so if you leave dispatch where they are, but you can get telephone CPR started by getting the bystander to do CPR early, you can actually push everything up to 30% survival. And if you actually get everything optimized in your system where you get fast turnout, rapid dispatch, you can even go up better. You can get up to the 50-60% range. And this is kind of what we're all trying to do. So rapid dispatch means that within a minute of the call arriving, you've got units headed that way. The units are given a minute to get turnout. Telephone CPR starts about 2.5 minutes. You get the scene again in 4 minutes after you leave the station. And you start high performance CPR, and that can get you to where most communities think is the upper optimum level of where you can reach survival with what we currently have, which is 50% in our existing EMS systems. So the rapid dispatch piece, as we've talked about before, is largely two questions: patient conscious, patient not breathing. If the answer is no, is a patient breathing normal? If the answer is no, it's no, no, and it's go, basically. And that's how quickly your dispatch center should be sending these calls out. And then right after that, the next thing they focus in on is basically giving CPR instructions. And this requires them to basically give very directive instructions to say what to do, how to do it, and exactly count with them so that you're actually coaching them and you're working with them. So you're actually going through this. And this in its own right takes a lot of work, but if you can do this, I can tell you that the dispatchers will make a huge difference in the survival rates in your communities. This is some data that came out from Sweden in 2020. You can see the brown box was basically no CPR. You can see the survival rate. You can see dispatch CPR. And then the last one is basically spontaneously initiated CPR, which is usually in the setting of having an arrest where you've got a trained medical provider. So you can see the impact that the dispatchers have in raising survival if you by just simply acting as coaches on the phone. So there's a new statement from the American Heart Association that kind of again speaks to this. I encourage you to share this, pull this down. It's freely available with your dispatch centers, and hopefully all of your dispatch centers are working hard to do telecommunicator CPR. And again, don't remember, and I would say don't forget and remember this, that the dispatchers are faceless heroes at the other end of the phone who truly make the difference between life and death. And they are the true first responders in our chain of survival. So please work with your dispatchers, and we continue to see more and more data showing the importance of dispatch CPR. At the dispatch center I oversee, which is Washington County's 911 center, we actually are working closely with something called the Resuscitation Quality Improvement Effort. This actually is through the Resuscitation Academy, which is something that I've been involved with for coming on almost 10 years now. Basically what we do is we work with the dispatchers. They actually get their calls reviewed. They also go through simulation calls. And you can see that having active feedback, which is like in most parts of EMS, by giving them accurate feedback, you can decrease the time to recognition of a cardiac arrest, the time to first compression, and this is all stuff that is part of a quality improvement efforts within an EMS system. Now, what's new in dispatch recently is probably something that many of us have been sort of interested in understanding, is how artificial intelligence will affect dispatch. So this is a study that was published last year in JAMA, and it was basically looking at a machine learning background algorithm that's sitting in the back, listening to the information that's coming into dispatch to see if AI concepts can actually help improve dispatch recognition of cardiac arrest. So the company that makes this is a company called Corti AI. I encourage you to go look at this site. In this particular study, they were able to show that with the artificial intelligence operating in the background, listening to the responses, listening to the breathing, listening to what's being said, they were able to improve recognition of cardiac arrest from 90.5 to 93.1. This was not statistically significant, but these dispatchers were different. Many of them had medical training. And the question is, how would this do actually in other settings? And this was also done in Copenhagen, Denmark, not in the US, where I think we have much more a range of dispatch centers. So the hope that we all have is that artificial intelligence will make dispatching of resources on cardiac arrest much, much better. So that's my big thing on sort of that chain of survival pieces early on: bystander CPR, telecommunicated CPR, and then hopefully in the future you'll start to see some interesting developments in the area of AI and CPR. The next thing I want to talk about briefly is when we arrive to the scene, which is when professional rescuers arrive, whether it's an EMT or paramedic, what type of CPR we should be doing. So there are two types of CPR currently being utilized, something called 32 versus continuous compression CPR. In continuous compression CPR, you give continuous compression in every 10th breath. I'm sorry, any 10th compression of breath is given superimposed on the compression. Now, ideally, if you time it correctly, you hopefully give it on the upstroke of the compression as you're releasing so that the air can go in. But timing and making that purely accurate is really difficult, in my opinion. But the question is, which is better? And there's been a lot of debate on this. And so I thought I would share with you at least our thoughts regionally in the metro area, at least in my personal thoughts at the agencies I oversee regarding 32 versus CCC. So going back again in 2015, there was a very large trial published by the Resuscitation Outcome Consortium. And it's the largest trial ever done in cardiac arrest. It's over 23,000 patients. And it was a trial basically trying to compare these two strategies. Now, in this particular trial, the strategies were compared for the first 6 to 7 minutes, after which, once an advanced airway was placed, they basically moved to a 10-to-1 ratio. But until then, they were able to compare the two systems directly. What did they find in this study? In this study, what they found was that the difference in survival to discharge was 9% in the continuous compression group and 9.7% in the 30-to-2 group. But furthermore, if you looked at the modified Rankin score, which is a functional score of how well people do when they go home, the survival rate was 7.7% in the 30-to-2, and it was 7% in the continuous compression arm. Now, you can see the p-values on the right-hand side do not reach statistical significance, but they approach it. So there was actually a hint that potentially the 30-to-2 was better. And if you go into the sub-analysis of this data and you look at what were the difference between the two arms, a couple of things that sort of were striking observations. One is that the chest compression fractions, although ideally should have been different, they were actually much more similar, suggesting that many people were not actually getting 30-to-2, but were probably getting more like continuous chest compressions. And if you look at the site level data, which is actually looking at favorable neurological survival per site, you can see here that in almost every site except one, the dots were actually either at the line of no difference or actually favored the 30-to-2 ratio. So this led us to actually look at this ROC data a little bit more closely. And I was actually involved with this paper that was published again late last year out of the ROC data set. And it basically looked at these two, but using some additional data from other trials as well as from registry data that we had collected. And we used a machine algorithm that was able to separate the type of CPR to 30-to-2 versus continuous compression. And what we found in this was basically that if you did continuous chest compressions and you adhere to that strategy, your survival rate was about 8% compared to 30-to-2. If you did that, it was much closer to 11%. And that difference was statistically significant. So what we learned was that to do good 30-to-2 is hard. But if you do it well, you have much better survival than doing continuous compression, which is much easier to do. And this makes a little bit of sense because remember, what you want to circulate during CPR is actually well oxygenated blood. And so if you're not getting oxygen into the lungs, the blood that you're circulating is basically deoxygenated. And so I think this paper, along with sort of that, a finer look at the CCC data, to me, was convincing enough that basically we went away from the continuous compression model that we had gone to about 8 years ago and went back to the 30-to-2 model and we actually continued this until ROSC is achieved, because even with an advanced airway in place, it is difficult to actually time the breath so that you give it on the upstroke of the compression. And so we essentially just continue to do 30-to-2 throughout the resuscitation until we get ROSC back with or without an advanced airway. Whether this is the right thing to do or wrong thing to do, I don't know, but I've talked to several experts in ventilation, and they all feel that what we're doing is actually within, is very reasonable based on the data that I just shared with you. So, and anecdotally, at least it appears, it's hard to interpret things because of COVID, but at least the last year, our survival rates in cardiac arrest seem to have gone up at 12 Valley Fire and Rescue, which is my primary EMS agency I oversee. Let me move now into something looking at the time to epinephrine. So of all the drugs we give in cardiac arrest, probably the one that has been looked at the most is time to epinephrine. And the question is, what have we learned about time to epinephrine? And so this next paper really looked at this influence of what happened in the paramedic 2 randomized control trial. So the paramedic 2 randomized control trial was done in the United Kingdom. And basically it compared giving epinephrine versus placebo and on outcomes from cardiac arrest. Now in that study, that one of the challenges was that it took them a long time to get the epi on board, close to 24 minutes in many cases. And you know, although you got more ROS back with epi, the neurological and functional survival did not appear to be statistically different between the two groups. So a lot of questions in that study about the benefits of epi, but one of the big things to remember about that study was epi was given much later. But this study actually, this publication actually looked at the time of epi, because there's been a lot of data suggesting if epi is going to work, you should give it earlier. And so they looked at basically their times, and you can see that in this particular study, their mean time to placebo is about 22 minutes, the same for the adrenaline. And so they were very similar in that aspect. But when you look at their data broken down by the type of rhythm, the shockable versus non-shockable initial rhythm, you can see that when you have a non-shockable initial rhythm, which is shown in the bottom graph here, and you give adrenaline, there's a much, much better chance of survival and based on achieving ROSC compared to the placebo arm. When you look at the same data in the initial shockable rhythm, you see that initially there's not as much of an impact from time to epi, but eventually you start to see the same thing. And this makes sense because in VF, again, you're dealing with that electrical phase. It's CPR that matters the most, and then timely defibrillation. And at some point, you may need to give epi to enhance what we call the coronary perfusion pressure and make the heart more amenable to defibrillation. But in a non-shockable rhythm, epinephrine early on is really, really important. And so if you look at the national guidelines here from ILCOR, which were updated in 2021. The ILCOR is the International Liaison on the Committee on Resuscitation. They basically continue to recommend the use of epinephrine, but for non-shockable rhythms, they're actually recommended to be given as soon as feasible during cardiac arrest, and that's a strong recommendation, although the, again, level of evidence, like in most things in cardiac arrest, is pretty low. But for shockable rhythms, they actually recommend initial focus on CPR and defibrillation, and then administration of epinephrine. But again, the evidence is quite low. And just to remind you, vasopressin, because it's no longer available or very costly today, is no longer recommended by any national organization in terms of in lieu of epinephrine. So for now, vasopressin has sort of been taken away. The recommendations really are to give epi early in a non-shockable rhythm as fast as you can. And for a shockable rhythm, focus on CPR, early defibrillation, and then move to epi if you don't get restoration of spontaneous circulation. All right, well, how can we get epi on faster, right? So that's the million-dollar question. And how can we do it in systems that don't have advanced paramedics, which many of our rural systems do? So this was kind of a provoking paper that also came out last year from the team from Utah. And they actually studied intramuscular adrenaline delivery to see if they could get it on faster and if it affected survival or had any adverse events. And the idea was here that many of our EMT basics in the state could give IM epinephrine for anaphylaxis. So we would just extend this to now allowing potentially IM epinephrine for cardiac arrest, since the first crew on scene often is a BLS only crew, or you have limited number of ALS providers on scene. So let's see what they found in their particular paper. So you can see on the top here, you can see that when they gave epinephrine through the anterior thigh, they were definitely able to get it on much faster, usually around the 11-minute mark or 10, 11-minute mark, which is considerably faster than what traditionally the IO or IV rates have given. You can see that the IO IV rates were more like 14 minutes or so. And interestingly, when you look at their overall survival, and this is a very small pilot study of 773 patients, so not powered enough to show a difference, at least initially, the IM, IO, and IV routes of administration don't seem to result any difference in the restoration of spontaneous circulation. It's 39, 41, and 42. So this is kind of a provoking study, and people are now starting to think about whether we should give IM epi or not. There are a couple of limitations of the study that I think are important to understand. One is this is a pilot study. There's no pharmacokinetic data. The other thing I think a lot of people are troubled by is the fact that it was giving into the thigh, which is below the diaphragm. And many of us think that drugs in cardiac arrest should go in the upper extremity or above the diaphragm because of the mechanisms of CPR. So I think we need to hear more data on this, but this is sort of interesting and something to keep an eye on, because I think you're going to hear more about this potential route of administration to get epi on early during cardiac arrest that could also be transferable to potentially BLS providers on a call. The next thing I want to talk about briefly is calcium in cardiac arrest. So there's a big paper that just got published in November, and many of us sometimes will give calcium in cardiac arrest. So this study, which was done again in Denmark, which was a study of IV versus IO calcium versus a saline placebo on return of spontaneous circulation in adults with out of hospital cardiac arrest. So and calcium has been one of these drugs that's been around for a long time. Sometimes its use has been more common, other times less common, but most of the times the time people give calcium or people are in the settings of initial rhythms of asystole or pulseless electrical activity. So this was a Danish randomized controlled trial, and they essentially gave calcium chloride 5 millimoles, which is about 735 milligrams. The dosing for us, if you're using calcium gluconate, is close to a gram of calcium. A gram of calcium gluconate is about 333 milligrams of calcium chloride. So it would mean this is roughly like giving 2 grams of calcium gluconate. This was given either IV or IO with the epinephrine that they were giving. If you had suspected hyperkalemia or known hypocalcemia, you're excluded from the trial. What was interesting in this study is they actually found that in the end, they randomized 397 patients, 193 in the calcium arm and 198 in the saline arm. And they actually found, when you looked at the survival differences between the arms, that when you look at ROSC rates, they're actually lower in the calcium arm. Now, they gave calcium here to everybody, not just the people with PEA or asystole, which is traditionally where we think calcium might help, but they also gave it to people with VF. And you can see that the saline arm had a much higher restoration of spontaneous circulation compared to the calcium arm. And when they look at what we call Bayesian analysis, which is to basically look at the probability of a drug being helpful or harmful, in this case, all the Bayesian analysis in terms of looking at ROSC survival or favorable functional survival all suggest that early use of calcium routinely in cardiac arrest is harmful. So many of us who use calcium are rethinking how we use calcium, and probably calcium may not be a drug that you'll see used much early on, at least in cardiac arrest. All right, let's talk about drug delivery. In the past, I've talked to you before about IV versus IO, so I wanted to share some updated data for you in this regard as well. And it actually came from the same study, the calcium study that I just covered for you. So this was a sub-analysis of that study, and they actually looked at what happened after they gave a calcium IO or IV, and this was a post-hoc analysis of that data. And as you can see, they actually measured in the patients who got ROS, they actually measured calcium levels and compared the data in the IV versus the IO arm for both placebo versus calcium. And you can see in both of these both of these analyses, with both routes, the amount of calcium you had in the active arm, which was the calcium arm, versus the placebo arm, which was the saline arm, was really very similar. The difference was 0.24 and 0.23 for the IV versus the IO arm. And basically their conclusion was that there were similar increases in the ionized calcium between the IV and the IO arm. And in this study, most of the IOs were also placed in the tibial location. Now, previously, I've shown you this data where we've looked at amiodarone and lidocaine, and we've shown that when you give amiodarone IV, you get much better survival than if you give it IO. And so that's led many of us to think that we should not be using the IO. And the question becomes, why are we seeing these two different sets of results from these two different studies? So I think you have to think about, like everything else in medicine, you have to think about what you're doing. So when you give a drug IO, there's a lot of bone marrow fat. And the question then becomes, does it matter if the drug is one that likes fat versus one that doesn't like fat? If it's a lipophobic drug like amiodarone or fat-loving drug like lidocaine or amiodarone, then it's likely a lot of that drug actually gets absorbed into the marrow fat and never gets into the circulation. Whereas it's a drug that's not really fat um, um, likable, or what we call lipophilic drug, it may be that more of that drug then gets into the circulation and gets to the heart. So it may very well be that the type of drug that you use and its lipophilicity versus lipophobicity makes a difference. Obviously, other things may be at play, how the drug was given, whether it was a fluid bolus, whether the arm was elevated, whether the IO is above or below the diaphragm, and lastly, the quality of CPR. So there's still a lot of debate about, where's the ideal place to put an IO in. At least in our, in our setting and in what ILCOR setting, the recommendation still is today that if you can, try to get an IV when you're resuscitating a patient rather than trying to get an IO. Um, and if it fails, if your attempts at IV fail, then I think IO is reasonable. But again, this is weak recommendation based on very low certainty evidence. In the metro area, we basically teach the first choice is the IV upper extremity. The second is the IO in the humerus to be above the diaphragm. And then lastly, we teach people to go for the tibial IO in the lower extremities. So we allow all three, but we have a preference, and our preference is the upper extremity IV. Now, humeral IO, unfortunately, is difficult to access because it's, there's a lot of activity around the chest during CPR. So people have been looking at other IO sites. This is a kind of an interesting study that came out of the San Antonio system where they've been teaching both their basics as well as their paramedics to actually pace IOs. And they actually been teaching them to do it in the femur. And so starting because they have a strong military presence and they have actually a military lab. It's an animal lab where they can teach, as well as a cadaver lab where they can teach the EMT basics and EMT paramedics in the San Antonio EMS system. They actually have been teaching them to do femoral IOs on a routine basis. And you can see that with time, the number of femoral IOs has gone up dramatically in their community, whereas the number of humeral IOs and the tibial IOs have dropped, and they don't get many IVs. They actually go for the femoral IO. And you can see in this particular study, when they looked at their data, this is not statistically different, but their IO humerus survival was 36% for ROSC, sorry, I should say. The ROSC rates with IO femur and IO tibia were lower. And so there's maybe a hint here that, again, the upper extremity is better, but I wanted to put this out just so that you were aware that this route of femoral IO is now being taught by people and is being used by people. It's thought to be an easier site to access. There's less dislodgement, easier to infuse. A few cases have needed surgical incision, which they also teach if they're super obese or you can't get down to the femur easily. It's just above the kneecaps. It's an easy location to landmark. But there's little data today suggesting improved outcome overall with it compared to other routes. And then if you do use this, please realize it's an off-label use of the EasyIO, and you should be using the long yellow needle, which is the 45 millimeter long needle. So they're all 15 gauge, but it's the length that's the difference between them. All right, so we've covered some things about drugs. We've covered some things about CPR, dispatch. And I'm going to shift now talking about shock refractory VF. So when you see cardiac arrest, the most resuscitatable rhythm you want is to have that ventricular fibrillation. That's where electricity works, and that's where we get the majority of survivors. But unfortunately, not everybody we find in VF will respond to a shock. Sometimes they will to the first, sometimes to the second, but sometimes they stay refractory. And in this particular instance, we then move to giving epinephrine. And then we also add in our antiarrhythmic drugs such as amiodarone, or in some instances lidocaine, depending on your preference and what you have available to you as an EMS agency. The question is, can we do more with anything else? So this is what VF looks like, and when it's failing to shock, you can start to see that it becomes a little bit coarser, a little bit wider, and the amplitude goes down and doesn't look as favorable. And the question becomes, can we do anything else here? And one of the things that's always been out there is, can we use beta blockers? In fact, those of you who follow any of this closely will know that amiodarone is a drug that is thought to act in part because of its beta blocker activities. And we know that why would you consider beta blockers? So beta blockers actually reduce myocardial oxygen requirements. They've been shown to reduce the number of shocks needed. They actually help the function of the heart post-recurrence. Remember, the heart's also irritable after you get them back, so there's often quite a bit of irritability. So in that situation, you can actually also give a beta blocker to reduce recurrence of VF. And at least in some models, it's been shown to prolong survival. So there are two small papers that have come out, one from Minnesota and then one from Korea. And these were patients who had failed standard ACLS care, which included 3 shocks, 3 milligrams of epi, and 300 milligrams of amio. And they basically then moved to a model in which they were given a beta blocker, which in this case is a drug called esmolol. In that particular setting, when they went to that, they had 4 to 6 out of the patients who had failed standard ACLS got resuscitation after esmolol. But the numbers were small, but encouraging, but they weren't able to go much further in this small trial that was published now about, again, 6 years ago. So subsequently, the Koreans actually looked at this and decided to study these refractory VF cases to see if in a larger population, could they show any benefit from esmolol. And they did exactly the same thing. It was given after 3 shocks had failed, 3 milligrams of epi had been given, 300 milligrams of amiodarone had been given. And they basically gave a loading dose of esmolol, which is an ultra short-acting beta blocker, plus a drip. And what they actually found in their study, which was had more patients, was they had better twofold increase in survival at 30 days, 3 months, and 6 months in the esmolol group. We've been kind of looking at this for some time and trying to make a decision in our regional area. And so the Metro protocol changed last year, that in the past where you failed with amio or you failed with lido, you actually were switched to the other antiarrhythmic. And we've decided to move away from that. And we basically give you one antiarrhythmic. It's either amio or lidocaine. And if you fail to convert after those 2 drugs, we now have incorporated the use of esmolol as a bolus. You get up to 2 doses of esmolol, 0.5 milligram per kilogram IV or IO. So this protocol just got implemented with us in the fall, in the start of January. So I don't have any data to share with you yet, but it is being used by other systems as well. And it'll be interesting to see if we can get some of these shock refractory VFs back by the use of a short-acting beta blocker. Now, we're not using a drip because drips are problematic, so we're just giving boluses, and we give two boluses up to 5 minutes apart in cardiac arrest that are refractory to shock. So by the time they get to esmolol, there's usually been at least 3 to 4 shocks in, along with epi and amio or lidocaine, and that's when they're going to it. So it's not early, but it'll be interesting to see if this changes anything for us locally. And hopefully we'll have some data in the next year to be able to report back. All right. Now let's get into some of the fancy stuff. So if you follow, again, resuscitation science, we want to bring people back from the dead. And that's the holy mission that many of us are on. And one of the biggest things that's been out there for the last probably 5 to 10 years is this concept of extracorporeal cardiopulmonary resuscitation, or ECPR. And this kind of gets back to that phase, the three-phase model we talked about. So early on, you want to shock them. The next place, you want to get good CPR, perfuse as much as you can, and then try to shock them again. That's the circulatory phase. But in that metabolic phase, the question is, what can we really do? Everything we've tried so far, drug therapies, none of them seem to have worked. But the question is, can we actually do mechanical CPR, find a reversible cause of cardiac arrest, such as a clotted off artery in the heart, open it up, and get people back? So this is, again, like I said, a concept that's been around for at least 10 years, maybe a little bit longer, and people have debated it because we haven't had a lot of data. Now, a couple of things to remember. So when we talk about cardiac arrest, we talk about three time frames. We talk about a no flow duration time frame, a low flow duration time frame, and then a high flow duration. The no flow is from the time the cardiac arrest starts until you arrive to start CPR. Now, if you get dispatch CPR and you get bystander CPR, depending on the quality, this may not just be purely no flow, but maybe an element of low flow. Once professional rescuers arrive and you start doing good CPR, so the right rate, the right depth, the right release, complete release with each compressions, we're now into what we call a low flow duration phase. But if you can get them to an ECPR center, you can actually put them on a bypass machine essentially and give them artificial circulation that gives them what we would call high flow duration of CPR. And that's what people have been trying to understand. Can we do this? And will it lead to saving lives? So finally, in the late part of 2020, we actually had a large trial that was done, but unfortunately was stopped very early because of some of the findings. But this study is called the ARREST trial. And this was done by the team from Minneapolis, which includes a hospital consortium that includes all the providers there. Now, a couple of things to remember about these studies in Minneapolis. The Minneapolis St. Paul metro area actually has a hospital-based emergency medical services system. So in this setting, each of the hospitals, the major centers, this is essentially own the EMS system. And so some things are able to be done there that are different because they have a lot of more financial access in terms of support because they're hospital owned. So what they did was they took patients who were 18 to 75, had an initial VF rhythm, as we talked about. That's the most survivable rhythm we get people back from. No ROSC after 3 attempts at defibrillation. They were all placed on a Lucas device. And they were all taken to a single center, which is the University of Minnesota, and they were put on ECMO at that point. Or they were basically randomized to continue standard ACLS. And if you got ROSC early, then you sort of fell out of this criteria. So you had to have persistent cardiac arrest after 3 shocks. And what did they find? So in this study, they basically were able to enroll 30 patients. They had 15 in the ECMO arm, and they had 15 in the standard arm. And you can see the survival at hospital discharge was 43% in the ECMO ECPR arm, versus 7% in the standard arm. This difference is profoundly statistically significant. And as a result of this, the Data Safety Monitoring Board basically stopped the study. So it was stopped after only 30 patients were enrolled, which is a very, very small study. If you look at this plotted out a little bit differently, this is looking at survival in terms of neurological function. You can see, and you go out to actually 210 days, so you're going out further out, almost to a year. You can see that the the survival in the ECMO or eCPR group remains pretty consistent. And the one survivor that survived at 30 days basically dies at 105 days in the standard arm. So this is probably one of the most powerful data sets we have that actually support this emerging concept of eCPR as a potential thing that you could do. Will it work in all communities? The answer is no. It's a very resource intensive, it's very expensive. But in some settings, you might see this work, and you'll probably hear about this as well. This is looking at functional survival, and you can see that the patients who got eCPR all had reasonable return of neurological function as measured by the CPC score. So their conclusion really is that ECMO facilitated resuscitations in select patients with refractory VF is effective. Unfortunately, COVID has changed how well this could be implemented. Many communities are trying to look at this, at least large urban communities. And there's actually ongoing new trials in Europe that will hopefully give us some more evidence in this regard as well. And basically what it means is that traditionally, when we bring people back, we don't get many people back after about 30 or 40 minutes. But with eCPR, which is the blue group here, you can see you can get survival as far out as 90 to 90 minutes after the cardiac arrest. The way to make this faster and faster is what they do in Europe, and it's now coming to the US, and that's basically the creation of mobile ECMO teams. These are teams that basically come rapidly to the site of a cardiac arrest, start the person on ECMO, which can be done by accessing the femoral artery, the femoral vein, and putting them on the machine. And then they basically take them back to the hospital, take them to the cath lab, try to fix any kind of heart blockage they may have, which is one of the most common things that leads to a ventricular fibrillation cardiac arrest. And then slowly wake them up to see if they can get them off the heart-lung bypass machine and get them back on their own. So this is what I would call very fancy technology. We have done it 1 or 2 times here in the Portland area, but it's still something we're also looking at as a potential futuristic venture for us. So this really speaks to what you can do in this metabolic phase. As I told you, here it's defibrillation. Here's very good CPR followed by defibrillation plus or minus a couple of drugs like epi and amiodarone. And then here it's all about trying to get them on eCPR. And the question is, can you create a system in your community that might allow that to happen? One quick point I want to just touch bases on is cerebral oximetry. So again, we resuscitate the heart, but what about the brain? So many people who we bring back ultimately die from what's called anoxic brain injury or ischemic brain injury. And what cerebral oximetry is a little tool that's now been developed that you can actually put on during resuscitation that actually measures the brain oxygenation. And this study again published by the folks from Seattle, we're really looking to see if early use of something called cerebral oximetry can help you predict whether the person is going to get ROSC, or actually if they do get ROSC, were they going to survive. So the EMS providers were collecting this data. They were all blinded to the data, and they were collecting serial data on this. And this is just basically a standalone monitor that you attach to the brain externally, like this patch, just like an EKG patch, but you just put across the forehead. And then these guys then looked at what happened in their community. What they found was that the initial RSO2 was not very different between those who got ROSC and those who didn't. But once you got ROSC, the ones that were going to survive ultimately with good functional outcome seemed to have a higher RSO2 than those in the first 5 minutes than those who didn't. And that difference was 18% among survivors versus 7% amongst non-survivors. So we have more work to do in this area, but potentially in the future, we might have some better predictive tools. And I suspect that some of you will see this slowly as technology becomes miniaturized and easier to incorporate into our existing monitor defibrillators. You'll start to see this cerebral oximetry also come into EMS settings. I'm close, I'm almost towards the end. I'm going to now talk briefly about post-resuscitation care, really focusing on, I think, what I call some of the things that we have to pay attention to also after we get someone back. So once you get someone back, one of the saddest things that we sometimes will see is a tendency for people to want to rush off the scene. And as they're packaging the person and readying them up to go, boom, they go back into cardiac arrest. So what we need to do is, once we get Ross back, we need to stop, take a breath, and realize that what we really want to do is, one, make sure we stabilize the patient optimally, and two, try to discover and treat anything that might have caused the cardiac arrest. And these are important things for us to think through if we're going to prevent rearrest in following resuscitation of restoration of spontaneous circulation. How often does this actually happen? How often does rearrest happen? This data, again, taken from the ROC Consortium, suggests that somewhere around 10 to 20% of people will actually rearrest. And what's sad is that once they rearrest, their survival drops dramatically. And the time to rearrest is around 6 minutes. That's the median time, that's the 50th percentile, and 4.4 minutes in the meantime. So that first 10 minutes or so after you get pulses back is a really tenuous time. It's a scary time for patients. And I think sometimes we tend to try to rush too quickly and don't take time enough to actually make sure that the person's stable because before we put them in the back of the rig. And this has also been looked at in the ALP study. And again, you can see that if you rearrest, your survival drops much more dramatically than if you didn't rearrest. And that affects everything in terms of also functional survival. So the Pittsburgh folks had looked at this data, and those two papers I just showed you were out of Pittsburgh. And they actually implemented what's called a Pittsburgh bundle of care post-resuscitation. So once you resuscitate someone, the first thing you want to do is go back, assess your airway, make sure that if you've got an iGel or a supraglottic airway, it's working well. If you've got an endotracheal tube, make sure that you're adequately oxygenating and ventilating the patient. The best way to do that is to look at your end-tidal C2 waveforms. The next thing is you should make sure that they've got stable vital signs, not just one set, but probably about 3 sets, one initially, one maybe 5 minutes later, 4 minutes later, and then one finally around the 10-minute mark. We are now recommending that you target an initial MAP once you resuscitate them of greater than 65. How would you do that? You may need to use some fluid, you may need to use some push dose epi, or even consider norepinephrine drip if you think they're in cardiogenic shock. Then I think it's important to start them on antidyservitic therapy if you haven't already given it. Start some external cooling if you can, because we know that that'll help the brain recover. And then at some point get a 12 lead. And this is in that 10-minute time frame. And then if they've stayed like that, then move to the hospital. And they've actually shown in their system that the so-called stay and stabilize post-ROSC approach has reduced their incidence of rearrest dramatically. A couple of things quickly about the 12 lead, because we recommend you doing a 12 lead. What's really important to understand is after you do a 12 lead, if the heart's been in cardiac arrest, has been shocked, there's going to be quite a few changes in that 12 lead that are related to the fact that the heart itself has been kind of stunned by the cardiac arrest and the defibrillation. So you can see that the heart, the ECGs, initially often will show STEMI, but by the time they get finally to the hospital, it doesn't show STEMI anymore. And sometimes they will show ischemia, and by the time they get to the hospital, the ischemia is gone. Whereas the opposite, the initial non-ischemic cases go up with time. So this tells you that after a cardiac arrest, the heart's kind of readjusting itself. So don't get too caught up in what you see on the initial ECG. Consider doing an ECG in that first 10-minute time frame. And then maybe even consider doing a serial ECG and repeating it before you arrive at the hospital, because things change, and that's important for you to understand that the heart is kind of recovering from this ischemic assault in conjunction with cardiac defibrillation, which is also an electrical assault on the heart. So we have a new post-cardiac arrest resuscitation protocol that kind of builds some of this stuff in, and I'm happy to share this protocol with anybody if they'd like to see it. Lastly, I'll just close briefly with a paper that has been published recently as well that looked at when should you do angiography in patients with cardiac arrest who don't have a STEMI when they arrive in the ED, when they repeat the EKG. This study was actually published in the New England Journal, and again, I think it's in December of 2021. They looked at these patients and they basically compared early angiography versus delayed angiography, and they actually found no difference between the two groups. The survival was 46%. Again, it was not statistically significant, but it looked pretty close at 0.06, and you can see that the delayed group did much better. So, what these studies are showing is that our tendency to sort of want to rush things and take people to the cath lab, particularly when it's a non-STEMI, or even after you get rushed back in the field, to rush to the hospital. Sometimes that actually is actually detrimental for our patients. So I'll close with this with this sort of slide that I remind you that basically the Resuscitation Academy concept of everything is about the chain of survival, and this does not include the survivor network, but basically it's early access, early CPR, early defibrillation, early ACLS, and then early post-resuscitation care, surrounded by what we call the frame of survival, and that basically is your leadership, your commitment to quality and excellence, training on this, because these are calls where what we do matters and we can save lives, and lastly, a culture of continuous quality improvement. So I'll stop there, Sean, and see if there are any questions that came up in the chat. And I apologize if I've gone fast, and I'm sure there are questions, but happy to take them offline as well if they come up.
All right, yeah, just a couple questions. There's a lot of information to go through, and I appreciate you doing that. One of the question was, so epinephrine and arrest, as you said, if it's going to be given, needs to be done early, and its efficacy and pre-hospital arrest there's some questions. What about anything you've read or anything you guys are looking into for like just a continuous epi drip through resuscitation versus just boluses every 4 minutes?
Yeah, that's a good question. That actually has been looked at in an animal model, and they did not find a difference. That was looked at again by the Resuscitation Outcome Consortium in something called the Pig Rock, where they looked at this, and there was no difference between infusion versus bolus dosing. So it is not human data, but the animal data was not supportive of that concept.
One of the questions we talked about access. Somebody asked about EJs. Are in Washington County, are you still using EJs? I know for most services they've kind of gone away from EJs because of the low frequency and high risk.
So I like EJs. I find them, they're my personal favorite. I've actually popped them in on a code on a scene when I've shown up when they were struggling to get an IV. So the problem is that there's a lot of activity around the head and neck area because we prefer to have a 2-person bag valve mask ventilation technique. So you have one person, holding the mask, one person basically squeezing the bag, and trying to get to the neck is not always easy. So I suspect the reason it doesn't get looked at is that the neck has got a lot of activity. And to me, if you're going to ventilate, if you've got the resources, a 2-person technique is better than one. And at least for, again, TVFNR, we send 2 heavy assets to every cardiac arrest, which means we typically will have 2 engine companies with, which would be, or at least anywhere, or a medic unit and engine company. So we have 6 to 8 people on every cardiac arrest. And so that may be one of the things why I see less EJs, but I love EJs. It's hard to get to the neck. And I think there's still this sort of what we learned first, the tibial IOs are still very popular because the legs are available. You saw femoral IOs are popular, but it's about how to access the patient.
That's a good question. What do you have to say about the heads up CPR?
It's funny. My slides are going to be about heads up CPR. I had this at the end, but I'm going to go through the end. And I'll tell you what my summary point is. So I think here's the problem. Heads up CPR, the data right now is coming out. There's no randomized controlled data. Okay, it's basically conceptually very interesting. It's conceptually very, the idea is that you By elevating the head, you decrease ICP, so you increase cerebral perfusion pressure. So hopefully you get more brains back than you get just hearts back. So that's the concept behind it. But what's really needed are clinical trials. And the problem is when you don't have clinical trials, you can spend a lot of expensive equipment. The other thing about heads-up CPR is you cannot do heads-up CPR without a system in place. And that system in place requires you to have active compression, decompression CPR. So that's essentially one of those compression devices that Zoll makes, or you can get the Lucas device. You have to have an ITD, and then you have to have the sequential elevation. You add all this together, this is a significant cost. You ask me, where am I going to put my money in? I will tell you where I will put my money in. I want us to get to the scene fast so they're in VF so we can defibrillate them rapidly before I spend money on heads-up CPR until I see good randomized control data. So long answer to a short question, but that's my answer.
Oh, one more in here we'll ask. I think this probably comes mostly out of the Alps, but amiodarone versus lidocaine, one better than the other?
I think that, so if you are a purist, I think that amiodarone does have, I told you, that beta blocker activity. That's why people like to use amiodarone. The problem with amiodarone is that the current formulation we use is not a push dose formulation. You have to draw it off. And that's one of the challenges that comes in vials, whereas lidocaine tends to come in a push dose pre-made syringe. So I think that on the ALPS trial itself, the data, at least for witness VF, EMS witness VF supported amio, most of us locally tend to use amio just because of its we're just partial to, I think, the fact that it's got 4 levels of antiarrhythmic activity: beta blocker, sodium channel blocker, potassium channel blocker, and calcium channel blocker. And those 4 elements of it, I think, is what we prefer. And at least I think if you think that the cause of the cardiac arrest is ischemic, the data, at least in animal models and from EP specialists, would be that amio is better, but it's not the easiest drug to give. So the problem with EMS is practicality versus what we do. So good question. These are good questions. I wish I had better answers for you.
Okay, I think that gets through most of the questions. I mean, one other, so supraglottic airways, if that's what you're using initially, do you believe there's one better than the other?
So we're using the iGel, and we moved to the iGel 2 years ago. And the reason we use the iGel is you have sizes all the way to kids. So that's why we like it, as opposed to having different. I don't think there's any data. There was some concern that the King was causing some compression of the carotid arteries, but that really hasn't panned out in subsequent studies. So most people, I think, if you're using the King, I think it's okay. We like the iGels just because you can use it down to kids, and the data actually supports both the King and the iGel as being easier, quicker, faster to place, and having better outcomes or equal outcomes compared to endotracheal tube intubation. So we haven't switched away from the iGel. In fact, we had just had a kid this morning we resuscitated from a traumatic cardiac arrest with the iGel. So I think the key is not sort of what airway you place. It's once you place the airway to make sure you got oxygenation and ventilation. How do you assess that? You look at your end-tidal CO2 waveform to make sure you got a good capnographic signal or capnogram signal, and you make sure that you've got, obviously 100% oxygen running in.
All right, I think we will end her up there so we can have a quick break before the next presentation. Thank you, Dr. Daya. Lots of really good.
Thank you for the invitation. Sorry if I always talk too much.
No, you do good. Thank you, sir.
Take care. Have a good day.